right, welcome everyone. Thanks so much for coming. I have gotten word from Sarah Faye that food is on the way, so hang tight. There is water if you want to grab some. Welcome to the January 1st VA Scholars Meeting of 2017. Just a heads up for you, our next session will be on February 2nd, Thursday, instead of a Friday, and Lynn Dane will speak about some of the exciting work we're doing in nursing. So I wanted to take a moment and introduce Dr. Dan Elliott, our speaker today. Dan is Medical Director of Christiana Care Quality Partners, which is a network of providers working to improve quality and value of medical care in Delaware. He's also Medical Director of the CCQP ACO, which represents a partnership of 3 hospital systems across the state. And this, gives him a unique perspective and insight into the subject of health reform and transformation, so it's pretty convenient that he's be speaking about that today with us. Prior to serving with CCQP, Dan was Associate Chair for Research and Scholarly Activity in the Department of Medicine. He was Project Co-Director and Director of Evaluation for Bridging the Divides, which was a project funded, for those of you who haven't heard of Bridges, it was a project funded by the Center for Medicare and Medicaid Innovation, and it developed care management services supported by information technology to improve the quality, cost of care for patients following coronary revascularization. Dan earned his BA in Economics and Political Science from Duke, where he was a Howard Hughes Research Fellow. He earned his medical degree from Jefferson Medical College as a Delaware Institute for Medical Education and Research scholar. He completed his residency in internal medicine and pediatrics at Christiana and Nemours. He served as chief resident in internal medicine at Christiana. Subsequently, he completed a fellowship in the General Scholars Program in the Division of General Internal Medicine at Penn. And it was during that time he also, because Dan's a slacker, earned his master's in clinical epidemiology with a concentration in health outcomes from the School of Medicine at Penn. In addition to his work with Christiana Care Quality Partners, Dan cares for patients as a primary care and a physician and a hospitalist. He is active with the American College of Physicians and the Society of General Internal Medicine, where he served on the Evidence-Based Medicine Task Force. So with that, I will turn it over to you, Dan. Thank you.
Thank you. All right, you've already surpassed all my expectations. I mean, clapping when I stood up here. No, it's actually great to be here. This is a super informal presentation. What I learned from where I live is that there's a lot of things that are happening in programs that I'm involved in that people may know it by name or know it by sort of something that's on their insurance card or something like that, but don't really have a good sense of what it is and what it means and where it's going. So unfortunately, the only way to get to that part when I was given the title of Health Reform and Transformation is to talk a little bit about the current state. And there's, somebody suggested I titled the talk, Making Delaware Great Again, but I really didn't think that was going to go over that well. But it's interesting times, right? I mean, that's the bottom line. It's interesting times. So so many of you in the audience are much more an expert on sort of the current politics and things that are happening. But so I'll just give a little bit of introduction as we go through about current health reform and some of the national efforts, and then we will sort of move a little bit into the state experience, but it's really at the summary level. And then we'll spend some time on networks and ACOs in our area, which I think is interesting and for the purposes of you all, I think presents some real opportunities for scholarship and for understanding, how does data analysis fit in, where does, the types of things that, we as VI scholars tend to be involved in, where does it fit? So, and that hopefully we'll have time for a little bit more of a conversation. And I do not presume that my words are bread, so when we get food, we will stop. I promise, right? So you don't have to get nervous and antsy. As soon as they're done setting up, we'll take a little break. But again, this is, it's kind of, it's an amazing time. Like this feels like yesterday to me. Yesterday. Like I can't believe it was 6-7 years ago almost. I mean, it's crazy. I actually give a talk around the Affordable Care Act, which I enjoy giving because I think we're reaping the fruit of some of the political process that happened, right? So the political fight that's happening right now is less about ideas and more about I was wronged in the process the first time, and I'm not going to let you forget it, right? And it's an interesting thing to keep in mind as we go through our current political climate when there's a lot of, all we want is different than what we have. A lot of that is driven by, I'm just frustrated that you passed a bill, this is Republican speaking to Democrat, that you Democrats passed a bill through a reconciliation process that redefined, 1/6 of the U.S. economy without any of my Republican side approval. So now what we're living out currently is, oh yeah, well now it's my turn to say that everything you did was wrong. I actually heard a Republican congressman recently say, no one expected the first time that we reformed healthcare to go well, right? It's such a complicated system, such a systematic, such a huge overhaul. You can't expect to get it right the first time. And I thought it was really insightful. He said, because it was a purely Democrat bill, every time it went bump, every Republican just stood by, my fingerprints aren't on it, I'm not part of it. And honestly, the sad legacy of Obamacare is that it's really a reflection of our sad and challenged democratic process. So, it's hard to have optimism in light of that, right? Because we can do the same thing again. Now, I'll use the same Congressman Burgess's comments from, again, about a month ago, and he said, and I was glad, because we asked him, what are you going to do differently? How is this going to be different? And he said, we recognize, we being the Republicans, we recognize that no one in America wants a 2,800-page Republican bill to replace a 2,700-page Democrat bill. Okay, that was insightful. And for those of you who have been paying attention at home, this thing called MACRA went through, which repurposed, and MACRA it's a comprehensive reform that brings a lot of the quality measurement, things that physicians were involved in and increasingly coming under. It organized a lot of those things. So meaningful use, the way we use computers, quality transformation, the way that we work as teams, sort of economic utilization costs, things that we do in terms of how our patient outcomes happen, and the quality measures that are related to patient care. MACRA repurposed all of those things under one program. It's controversial. I mean, it's kind of painful. But the interesting thing about it is it was passed with almost unanimous bipartisan support. And what's going to be different about what Congress has, I hope, learned, and hopefully the Republicans are paying attention, that when a big bill goes through and it goes bump in the night, when you have a bipartisan foundation, there's actually opportunity. Now the challenge is, where can folks agree? And we are not going to solve that problem. I'll throw out a few little highlights here, but again, there's a lot of you who are much more expert and could go much further into this conversation. So we're just going to use this as a launching pad, and it's just hard to ignore as we try to get down to the level of Delaware. So, I think for those of you who haven't read it, I thought this was fascinating. Barack Obama wrote an article in JAMA. I don't know if you saw it. I mean, it's fascinating. I mean, it's really to have a sitting president write an article published in a medical journal. I mean, obviously it's unprecedented. I think it was fascinating. It's worth your read. It was, I can't remember when it was, back in July. It's worth your read. It's an interesting framework. Some of the analysis, people have taken issue with, people will take issue with anything, right? But generally, he said what we set out to do, we did. We expanded coverage, we decreased cost growth, and we started delivery system reforms. And that really is what it was designed to do. He didn't focus so much on the insurance market reforms, and that was a big component of it. But a lot was accomplished. And when you look back to, 2010 is not that long ago. And it does feel like yesterday, but really a lot has changed. And I think there's a lot of things that have happened through Obamacare that we're going to have to, as a country, as you're watching this discussion, you're going to be teasing out what's policy, what's intent, and what's politics. Unfortunately, we seem to be dominated by the politics piece. So obviously, this is a huge change. The picture didn't seem quite as big on my slide when I did it, and my computer is a little bigger. But we're in, it's a crazy world from a healthcare perspective, and it's hard to know what's coming next. I actually, believe it or not, I actually feel a little bit optimistic, and maybe it's because of late you're seeing some changes, you're seeing some people understand that, political speak, campaign rhetoric, those things are easy to say, repeal and replace. When it comes down to it, gosh, that's really a much more complicated piece. So I think you're starting to see some components, some people, different, people within the Republican Party starting to think, we really can't do what we said we were going to do as easily as we said we've done it. You've seen, there's groups of Republicans who are saying, yes, we believe in these ideas, but we're not going to move forward with something until it's actually, there's a replacement, which, just based on the legislative process, will not happen by March. We can be pretty sure about that, right? So a lot of the deadlines that have been sort of artificially put over top, they're just not realistic. And it's going to be an interesting, and I'm sure a little bit bombastic and probably a little bit painful for a lot of us, to watch how this unfolds over the next few months. But if you believe in the democratic process, which I hope most of us do, potentially there's an opportunity here as people are understanding the reality of what they're trying to undertake with the lessons learned from Obamacare. Nothing to say other than buckle your seatbelts, right, in terms of what's actually going to happen. I think it's important to understand, like, what are some of the Republican principles. Ironically, some of the Republican principles are included in Obamacare, right? But once they sort of became Democratic principles, it's hard to pull them back and hard to say we own them. I think there'll be a rationalization of that over time as people realize that, the market exchanges, which was a classically Republican free market idea, at least in its concept, is going to be something that's going to actually be a successful piece of what our system is next. Reforming the individual market where people can buy insurance in a way that actually makes sense and is slightly rational as compared to what it was before, which was wholly irrational, is a step forward. So there'll be things that are kept there. So some of the big questions, obviously, for those of you who follow this stuff, the political junkies, that the Republicans are pushing forward with what's called reconciliation, which means that they can, as opposed to taking Obamacare as a huge lump sum and just saying we'll get rid of it, because again, it's just impractical. It would cause such chaos in the market. So what they're going to do is take components of it piece by piece. Now that's going to have the same thing. People are going to live in this uncertainty, which is going to have real market implications. Certainly insurance markets and others will be really challenging. But what they're doing is they're going to say there's certain components of the bill which we can get rid of without a huge legislative effort. And that's going to go through the same process that actually Obama used and the Democrats used to put the bill in the first place. So it's this funny sort of tit for tat of our political process, which is somewhat unfortunate. But some of the things we know they're going to do is eliminate the mandate. So the whole system, for those of you paying attention at home and like this kind of stuff, the whole idea was people have to have insurance, because if you have only people who need insurance buying insurance, it's an irrational market and the prices get too high, right? So the mandate is a key part of it. It's part of the three-legged stool that if you don't have it, you're going to fall to one side. So it's going to be, if you eliminate employer and individual mandates, people don't have to buy insurance, there's not penalties. That kind of is a big one. It starts to undo things. Certainly subsidies, the majority of the people that buy insurance on the exchanges are subsidized. I'll show you the Delaware numbers, but the vast majority have some subsidies. And that's not Medicaid, right? There's Medicaid, which went to a higher level under Obamacare, but then the private market, there's significant tax subsidies to a much higher level of income, up to 400% in most states. And, as you get rid of those things, what does that mean? And, I can't understand a world where people would actually move backwards and have 20 million people who now have insurance, get off insurance. So it'll be interesting to see how that plays out. But these are some of the things that are there. Do they get rid of some of the market reforms, the ability for people to stay on their parents' insurance, the limits to insurability, these things which were actually the things that were part of the Obamacare that didn't have much to do with healthcare delivery. They were much more insurance market reforms, and the original critics of Obamacare actually used that as you didn't really do anything except reform the insurance market. But those things are important, because if you have insurance and then you get sick and then you can't afford to pay your premiums and you lose your insurance, well, guess what? That's not right. I mean, none of us would say that's right. And so Obamacare did a lot of things in that space which are subject to being removed, potentially. So anyway, as a classical Republican ideas, the food is up. I promised you a break. We'll do it. Actually, let's do this. Let's finish this one slide because it'll take 30 more seconds. So cost sharing, it's more high deductible plans, health savings accounts, this classical idea of having skin in the game and trying to rationalize the healthcare market. It's crazy to imagine. That certainly has to play a part of it. The Republicans tend to lead with that and think that that'll drive things. If that's the case, there's going to be huge implications for healthcare systems, transparency, visibility, costs, which right now you can't have a market if you don't know what you're paying for, right, and what it's going to cost. And right now, healthcare has no way to make that visible. So again, the ideas of using free market capitalism are appealing to many and make sense in a lot of ways, but it's hard to do that if you have a market that's shrouded both by regulation and price, basically lack of price transparency. And this other idea, which I think most people would think is a good market idea, right now every insurance company has to register within a given state. So that has huge implications because insurance and the success of insurance companies is often based on scale and pool, right? You have to be able to pool risks. So if you're in small markets like Anybody live in Delaware? Right? You're in small markets, it has implications for what policies are available. And that's an important thing. And the Republicans, again, one of the planks that they've sort of put forth before is eliminating state barriers so that insurance companies can sell across multiple states. And that has real implications for where we're going to go after you get your lunch. So we'll take a little break.
I think someone put you there, so.
Okay, get away.
Have you seen projections that
Sure.
Yep, it's good enough.
It's actually, it's not as much as in Delaware.
It is better with the included light.
Yeah.
It usually is like in any room that I'm in. Okay. So, but.
I mean, some people say, and again, there's
We put it on the website because you said it out there.
So I guess I thought you had part of the
there's some level of honesty. So there.
Yeah.
So they make a subsidy. So there's still ways to subsidize. Okay. Yeah, it's a really
Sorry? Oh, you were
Hey, Neil. How you doing? Like what else am I gonna have? Yeah.
For those of you who already have your seats, any questions or comments just while we're waiting for everybody else to join us? Obviously, it's a huge topic, right? And we're not doing the full topic justice, but.
So how does it work with increased state control and eliminate state barriers to insurance? Isn't it contradictory?
Well, sometimes principles run up against each other, right? But yeah, so the idea is, I mean, this is where the details get really fuzzy and where things get challenging. But the idea is, can we do more with, certainly in the Medicaid program, can we do more from a federal level instead of giving you, right now, there's a state partnership and you spend a little bit, we spend a little bit, and you get a little bit based on all these programmatic components. Instead, and this is something that was in Paul Ryan's plan for sure multiple times, I'll give you a block grant to the state and say, you get X amount of dollars for Medicaid, you do whatever you want with it at the state level. So the way you control your spending, it's less about mirroring federal programs and more about just, you have this bucket of money, go do the best good you want with a couple quality parameters and other parameters in place. So the idea is that you give a lot more flexibility. That makes sense in some ways. It's also scary to a lot of people, right? Because if you live in a world where you really don't think things should be regulated and you have a worldview where people don't need coverage and you have a bucket of money to spend, you may allocate it differently.
Anybody send over any of their sections for the renewal?
All right, so maybe we'll go ahead and move. Any other questions just on the little ram through the first section? All right. It is interesting, the mandate, Mia was bringing up the idea of, is that what really got people upset, like being forced to buy insurance? And that was a piece of it, right? So I mentioned and emphasized the political process because I think that's the thing that drives the pain, like the anger and the visceral response. There are a couple other notable things that people criticize Obamacare for, and you can go through a whole list of these in the plus and the minus category. But the other things they do come up with is that the employer mandate is a job killer. You hear that a lot, right? And again, you have people, economists will argue both sides, but the idea is that you know, if I get to 50 people, then I have to have a certain level of health insurance. That means that I don't want to hire more people to put me in that category. So there's components there. And then finally, the last piece that people really point to is that the conversation about cost was never realistic. So the CBO estimates, the Congressional Budget Office that makes estimates about how much legislation costs before it goes forward, you know, they have a series of assumptions when they make those efforts or make those estimates. Everybody understands that who does research and does models. You have assumptions, right? The CBO has assumptions, and it was known at the time that there wouldn't be the political will to keep some of those things in place. So the numbers were probably not accurate. And truth be told, if you're going to insure a lot more people, which was the fundamental goal of Obamacare, you're going to spend a lot more money. And we're probably better off having that conversation out in the open than trying to hide it behind policy numbers, right? And so I think that was another thing that's left a lot of people, you know, frustrated about this. All right, so I can't tell if I'm going forward or backwards. I'm going backwards. Yeah, it's okay. So insurance coverage in Delaware, so that's the national piece, and that's going to change dramatically. And if anybody tells you they can predict it, just walk the other way, right? It's going to be an interesting debate. I hope it doesn't get too ugly, and honestly, I hope that we get to a place where we can have some kind of bipartisan peace. It's hard to imagine in this climate, but it's what's necessary, especially when you're dealing with this much of our national economy. So I think it's kind of interesting to look at insurance breakdown. What I found in this job is that, you know, we're not, from a healthcare perspective, frontline providers, but even people all through the system aren't really paying attention to the business climate and what's happening as things move forward. And insurance is a big deal. I mean, for those of you who see patients, if you're in the hospital, you may not feel it as much, but in the primary care world, I feel it a ton. You try to get somebody to see a specialist and they can't because of this insurance, that insurance. I mean, horror story after horror story about sort of narrow networks and limited coverage, particularly Medicaid and Medicare programs. It gets really challenging. So it's important to keep these things in mind. So our population, you know, just over half are in employer programs. So again, that's always been the hallmark or the benchmark for insurance coverage in our country. It's the same here. Medicaid, 236,000. Interestingly, so Mia also asked what the difference is between, you know, what happens when it goes away, and I will show you that. But Delaware already had very generous Medicaid regulations. I think they were, making a number up, I think it was like 166% of federal poverty level already. And so they were sort of maybe they're 200% of federal poverty level, and Obamacare took it up to like 166. So we were already more generous than other states in terms of our Medicaid, what your criteria were. So we actually only had attributed to Obamacare only 6,000, and just so everybody knows, Obamacare is totally fine. It's not like a bad, it used to be like a bad thing to say Obamacare, like it meant you didn't like it. Obamacare is just the way we talk about it now, just in case anyone's still under that idea. But anyway, Medicaid is expansion of 6,000 under Medicaid in Delaware after Obamacare and the markets went into place. The individual market, so this is where the health insurance exchange is. Our exchange was done, Delaware's too small to start its own exchange, so we were maybe 10 or 12 other states were like us, and we let CMS or the HHS run our exchange. So we were part of a federal exchange, but it had local Delaware products in it. And we had about 25,000 people that bought insurance through the individual market. And this is where, has anybody ever tried to buy insurance in the individual market? Or have a family member try to buy individual? It's really hard. Now, it may not be hard for young, healthy folks. It's really hard for anybody else, particularly if you've left a job and you have chronic medical conditions. That was the part of the market that just didn't work for people. And those are the people that need it, right? Or at least, would benefit from having insurance. So, you have 25,000 people who bought insurance through the market. I don't know how different that was from before, but notably, 22, so the vast majority of those receive some kind of tax subsidy. So that's usually in the form of an advanceable refundable tax credit, right? I think it's like way out there. You have this real meaningful tax subsidy that's apparent to you to buy that coverage, and that's graded based on your income until you graduate out of that. Then 186% or 186,000 in Medicare. So you can see here, this is the graph I was telling you about. So Delaware is in the blue down here in the bottom right. So we were right around 14% uninsured prior, or in 2013. So even a couple years into Obamacare, but then the exchanges started, and exchanges really, the first 2 years of Obamacare were really insurance market reform. So when the coverage expansion started, we went down, and we're now below, we're like 8 or 9% now. And that's consistent with the federal numbers. You can see it's a little bit, says this is actually outdated. The most recent numbers for uninsurance as of the end of 2016 are actually like 8.5% uninsured in the country. So that's, I mean, a remarkable improvement. And we shouldn't pretend that that won't cost money, but coverage is a remarkable improvement. So this is just you get all these mailers, and people are trying to sort of make their sort of political case and help have people engage in this debate in the political process. If you look down here at Delaware, they're saying increase in uninsured if Obamacare is repealed, just taken away. They're saying we go back, 42,000 people in Delaware. And then this is interesting. You don't know what will happen in this market, but non-elderly, so non-Medicare qualifying adults who have pre-existing conditions, 163,000 people. It's a big portion of our population that all of a sudden you sort of set loose potentially in some of them will be in the employer market, but some of them will be in the private market. And that's where things get really, really tricky. So I think it's important, and this is important for those of you who work at Christiana Care. Almost $200 million in uncompensated care, right? And Brian really has a much broader view of this than I do. But the hospital is very interesting, right? Because it's tied up in all of your nonprofit status and a lot of things that we do are pricing in other markets. It really, uncompensated care that comes in and has to be subsidized somewhere, right? So those prices go elsewhere. When you have a more rational market and more people have insurance, then you can actually start to price in a more reasonable and rational way. And it has all kinds of other implications, which again, Brian would be a great reference for us to follow up with. But it's important when you think about, wow, $200 million uncompensated care, hospitals, doctors, other health system and delivery system partners start to, that's a meaningful component. All right, so the world where I live, and I think where a lot of us live, is we're kind of all geared up for this value-based transition, right? And one of the things that Obamacare put in place was this, we're going to move this whole world forward, right? We're going to actually start to think about getting off the fee-for-service train and moving to value-based payments. Nobody knows what the timeline is. Nobody knew at the time what it would look like, but put in place things like accountable care organizations, and we'll tell you about ours. Put in place all these different things, notably through an engine, or one of the engines called CMMI, which is the grant that Bill was the PI on that grant, the Bridges grant I think a lot of you are familiar with. That came through CMMI. So it was designed to really kickstart this whole transformation of healthcare. And so the question is, what happens to that, right? So insurance market reforms and other components are one thing, but also our healthcare system, the things we're focused on, we're doing sort of day-to-day transformation, working on trying to eliminate variation and do all these things. And those are good things, but they never really had a reason to be done, which is a terrible way to think about it from a purely practical financial sense. Like, why would I invest in something that sounds good but has zero financial return, right? So one of the things that's really happened here is that through the ACA and through the subsequent activities of CMMI and CMS, we've really accelerated the possibility of, so we actually have a financial model, or at least the potential of financial models that are just starting to develop that actually start to reward improvement in quality, standardization of care, some of those things that we want to do that before didn't really have a business model, so it was hard to convince people to put resources to. So a lot of the change that we felt over the last 2 to 3 years has really been because of these sort of the offspring of the ACA that have started to really push us in this direction. You give somebody a business model, now you can bring a CFO to the table, now you can start talking about what does this look like, and you see the engine start to very slowly but very substantially change. And we've seen that across the country. And you guys are probably familiar with this graph. This was last year, this was CMS saying we're going to move the proportion of our revenues that are in, of our payments that are in fee-for-service medicine, meaning you do what you want and I'll pay you for it. We're going to decrease that, diminish that, and increase the proportion that are in this dark blue. The navy blue is, alternative payment models. So some type of accountable care arrangement, something where people are on the hook for cost and quality. We're going to rapidly and dramatically increase that. And they've been successful in that to meeting there. They actually really surpassed what they thought they would do in their ability to move those systems forward. So this is where things like bundles, those of you engaged in bundle payments or understand bundle payments, that's looking at, a specific procedure or a specific episode of care. So bypass surgery, hip replacement, something that's very discrete. You look at the total cost and quality around an episode, usually something like 30 days before and 60 to 90 days after, depending on the way the bundle's structured. And you're responsible to decrease cost and to increase quality within that bundle. And then, so that's sort of a specialist version or a hospital-centric version. And then the accountable care models are doing the same thing, but on a broad population. So instead of just, one person getting their knee replacement, you're looking at every person with all their medical care. So these things were really kicked off because of this. So that value-based transition is a direct result of what's happened under Obamacare. And so this is my cute little way of saying, right, I think the train has left the station on this one, and it's, so this is one of the things, no matter what happens with all of the political process and some of the specifics of the insurance markets, et cetera, this transition is going to push forward. I mean, there's no way it doesn't. Which vehicle it goes through and how it gets done is going to be interesting to watch, but this is going to be a part of our future, and there's a couple of reasons why that are very logical and will now drive this. And in Delaware, for those of you who have followed this is not the first year that this has been a problem, right? So, state budget grim, right? Hoping to avoid tax increases. Yes, I'm hoping you do too. But this is where we are every year, right? And we know education is the biggest, maybe you don't know, but education is the biggest single bucket, and guess what's second? No surprise, right? And this was just a projection that was done as the state looked at its employee health benefits plan and the employee health costs. So about 120 to 140,000 maybe employees and beneficiaries, employees and dependents get their coverage through the state of Delaware employees. So by far the largest block in the commercial market. So when you look at this, you have a state contribution in blue, which is fixed in terms of budgetary projections. You have an employee retiree contribution, so this is the premiums that they pay, and that's pretty much fixed in terms of these projections. And then you have this thing in red, which is called the crud deficit, right? And so this is why the drive to value-based care is not going anywhere, right? Because what was happening at the federal level was really accelerated through the ACA and its passage is just bread and butter for everybody across the country. And now that there's been an organizational framework that's sort of started this sort of movement at the delivery system level and in the industry, there's no turning back because the pressures here are huge. So if you're the state of Delaware and you happen to look around and you say, we're not that big, and I wonder where our money's going, and I wonder who I should talk to about decreasing that deficit, right? It's a huge part of the conversation. So the fiscal pressures that drove a lot of the other conversation before, some of which was done kind of felt a little bit abstract, is actually going to start feeling a lot more real on a regular basis. This is happening state by state. No, Delaware's no different. And of course, Christiana Care is no different either, right? So these are actually numbers for our employees and dependents. There's a lot of reasons. This is a whole talk in itself, which we won't go into, but these are sort of 2014, 15, and 16 for our per member per month costs for our employees and beneficiaries. So anybody have any idea how much money we spend on employees and dependents for healthcare at Christiana Care?
$537 times 18,000.
Okay, you're pretty, times 12. This is monthly. Don't forget the 12. But yeah, so the guess, without doing the math, I won't hold you to that. Guess. Just throw a number out. Somebody help me. Throw a number. I don't care what it is. You can say 5.
2 million.
10 million.
10 million? Okay.
20 million?
20 million? Can I go a little higher? Can I?
So let's see, it's about.
Don't do the math. Your math brain's too good. Yeah, you just have to gestalt this one.
12 million.
12 million? Anybody?
60 million.
Anybody?
100.
Who said 100? There we are. 100. $100 million, right?
A year?
Per year. Yep. So it's healthcare is not cheap. I've learned that firsthand, right?
So it shouldn't be a surprise in a $1.7 billion a year organization that we spend 100 million on healthcare. No.
That's right. That's exactly right, because that's just what the industry is. But I don't think, until I took this job and started looking at numbers, I just didn't appreciate the magnitude of what we're talking about. And when you start to, you're like, holy smokes, wow. And when you look at the state budget and those numbers, you're like, whoa, these are real numbers. This has real implications for, like, do we pave I-95? Right? You know, I mean, you know, well, not 95, that's probably federal money, right? So, but do we pave 141 my way to work? You know, so really interesting things to think about. And these numbers go up every year, and we won't go through this again, but you think about the orange bucket up top is prescription costs, which are outrageous, going up 14 to 16% per year across the country because of specialty pharmacy and high-end drugs. Right, then you have the second one down, which is professional. You notice they don't pay the docs any different than they used to, right? That's a pretty stable part of the bucket. The green is outpatient costs, so you know things move from inpatient to outpatient. They price different in the outpatient world. Theoretically, that should be cheaper. It wasn't always that way in our experience, but it's another conversation. And then our inpatient costs, the hospital. So if you think about the world in buckets, that wow, this is okay. There's buckets of costs, and money's got to be spent somewhere. And it's an interesting way to look at it, and everyone feels the pressure. When you see your costs going up year over year by 10, 12% in this one budget line, what on earth are you to do, right? Because whose revenue is going up 10, 12%? Not many people, right? So this is really, we're in that same place that we were when when the ACA was really pushed through. And that was just the practical feeling of, hey, things are getting tighter around here, and I'm not sure I'm getting the value I want for my money. So Christiana, I'll just tell you a little about Christiana Care Quality Partners. So, because that's probably something that is confusing to most people. And it's likely going to be changing over the next few months. We'll see. But Christiana Care Quality Partners is a partnership that is with providers. So it's contracting with all the providers in this area. So we have about 2,600 docs and other providers who are in largely our service area, right? So mostly Newcastle County, a little bit New Jersey, Maryland, et cetera. And we have contracted with those providers as an entity to take care of our 20,000 employees and dependents. So it's been a really interesting piece. We've taken on some of the financial responsibility, taken on all the contracting responsibility for fee schedules and all sorts of things. I don't recommend doing that. It's really a pain. And it, you know, there's so much learning that's gone through. But the idea is, Christiana Care a couple years ago said, we got to stop this rate of rise, right? Something's happening. Can we align the providers and start making different decisions, right? And that's been a learning process through. There's a physician governance, which has been in place, and some pay-for-value programs that we've sort of started to test these waters on how do we actually get people. Because the way to bend that cost curve is, yes, there's policy, but really the only way things are really going to change is that we want to be assured at every level, every engagement, every interaction that we're giving the highest quality care at the best possible price. And that requires everybody to sit at the table, right? It's not something that can be sort of managed from above. Really challenging. So this has been our attempt to do this, at least our first. And I think it's one of the things that I've learned as we try to communicate this to physicians and providers. It's really a challenging way to change the mindset, right? To be thinking about, you know, cost. It's threatening. It's not always comfortable. And honestly, in my opinion, it's not always necessary. Sometimes we overdo the cost talk. So we got to back that up a little bit. But this is a framework that I use to explain to the members of Quality Partners to help them understand how we're being evaluated. Because from a market view, it's really important. And actually, I'll just jump through. Well, so basically you have this network, and for us, that's Quality Partners. But the goal is to have a high-performing network where we're making good decisions. We're only doing things that are appropriate from a clinical standpoint. We're looking at high quality. We're taking into account cost, et cetera, getting every patient what they need. And really, the view towards our success falls down into 1, cost, and 2, quality, right? And you get a report card in both of those, and it's remarkable. Like, you know, it's been a long time since I got a report card, but when you get these numbers, you watch people bristle. I mean, bristle at these. Wait, all that I do in medicine and all we do as a complicated healthcare delivery system group of providers comes down to like cost and quality? Like, yeah, right? Because people are trying to buy something. At the end of the day, we're a commodity. And it's hard to think of ourselves that way, and obviously I like to think of us much more in a much more lovely and grand fashion, but functionally, we're a cost center. We're a line item on somebody's budget that just keeps going up 10% every year, and they're trying to figure out what the heck can they do with us to stop that. Really challenging. So we have to, in the market, answer that and address that. So cost, you're basically the graph that I showed you. You're judged by hey, how much does it cost per month? Take all your costs and break it down by month per person and tell us what that number is. And you go to these conferences and everybody says, what's your PMPM? What's your PMPM? I mean, it's like hilarious. You know, that's how you're judged, right? I got to be. You're magna cum laude, right? I mean, you know, whatever your standard is, you know, that we've always used in other areas, this is how it's applied here, right? And, you know, so quality, then you have these sort of basic claims-based quality measures, some patient satisfaction, some other things. This is wholly unsatisfying to providers, right? Because it doesn't feel like it's capturing the essence. And I actually agree with that. I actually agree it doesn't capture, but we have to be aware of how we're engaging the market and how we're viewed externally. And this is how healthcare is starting to, you know, people are evaluating. So when people are buying, employers are saying, who am I going to use for my insurance? Where am I going to send patients? Show me cost and show me quality. So that's, anybody who's involved in this healthcare enterprise is going to be under that somehow, and that's what drives things. So, you know, there's obviously a lot of things that interact. You know, there's patient factors, there's, you know, all kinds of things about how benefits are, what your co-pays are, what care you have access to. There's all kinds of other things that are different than did your providers give you good care. But at the end of the day, nobody cares about that. And it just boils down to this. So it's a really sobering way to think of ourselves in a complex market. But I think accurate, and I think people have gone through it and starting to adopt some of those things and understand it, and it actually ends up being sort of a healthy self-evaluation or self-appraisal. So I want to tell you as well about, so we had quality partners, that was our first thing, and it's still going. And then last year we started this accountable care organization. So I alluded to a little bit earlier that accountable care organizations are, you know, they're sort of developed their programs. It's a program that was made available through CMS. So it's a Medicare program, and you basically can apply as a group of providers to say, yes, we will take responsibility for both cost and quality. That's total cost and quality for all of the patients that we take care of, right? And that's what an ACO is fundamentally. There's a lot of different things. So last year we started with 3 health systems and 200 primary care providers, probably about 700 or 800 docs totally, but 200 primary care providers. And we had about 26,000 Medicare beneficiaries that were in our network. As of January 1st, we added BB down here by the beach, and we added a hospital right here called Atlantic General, which is in Berlin, Maryland, a little bit west of Ocean City, Maryland. So we now have 5 health systems. We have also 2 federally qualified health centers, west side here, and then La Red, which is down in a little bit below Georgetown, or in Georgetown. We now have just about 300 primary care providers, and we're up to almost 50,000 Medicare beneficiaries. So remember, there were only 100, actually, who remembers how many Medicare beneficiaries were in Delaware? It's like a pop quiz. You got a free lunch, you got to answer a question. 180, I love it. So Dr. Paul's paying attention. So 180,000, of which about 7 to 10% are Medicare Advantage. So drop that 18,000. So we got 50,000 out of 160,000. So pushing almost a third of Medicare beneficiaries. Now we do have some Maryland folks, so it's not entirely in Delaware. But it's actually, my shtick right now is talking to these docs and saying, hey, look, you're part of a network that has the opportunity to actually really make a difference for Medicare in our state region, but folks around the state. It's just that no one in the country has this opportunity. No, there's no other single group of providers that takes care of, let's just be generous, a third of the Medicare beneficiaries across the state. So it's really unique. Bill taught me when I first came here that the best way to start every grant application is Delaware is a microcosm of the United States, right, Bill? Demographically and all the thing. I mean, we had the whole paragraph, right? And it would start everything. And it's really exciting because we have an opportunity where we're looking at a state that has a budget crisis, we're looking at something that requires wholesale transformation of healthcare on a really grand level. And guess what? We have the opportunity to impact it. If you believe that impact is ground up, not top down, we have the opportunity to impact it. We have all the hospitals, which 60% or 50% of your cost is going to be somehow affiliated with a hospital. So wow, if you can figure out how to manage costs there, eliminate where necessary, we'll say rationalize the use of the hospital system, but also be doing stuff on the outpatient level from the ground up, we have an opportunity to actually contribute meaningfully in this dialogue, right? And I really do believe that. It's an exciting thing that we're all a part of, you by virtue of just being part of Christiana Care. Also, and we'll talk about this, and we'll leave a few minutes to discuss it, you think about the opportunities from a research standpoint, looking at transformation at this level, really powerful, right? It's a microcosm of the U.S., right? It's a broad population. We're starting to look rural, urban, all the different things that we have and we've all talked about, amazing opportunities Medicare data coming through. Obviously, a lot of hoops to jump through and logistics about how to use that data effectively, but a really powerful opportunity that we are all a part of. Whoops. This is what the other thing I sell, and I think it's important. The ACO is very public, so all of our numbers get published on a website at the end of the year. Be interesting. We just finished our first year, so usually it takes until about probably late summer, early fall before we know how we did. You get these quarterly updates, but everybody tells you they essentially vary randomly. So you don't know what you're going to get until you get what you got, right? So that's a little bit of a challenge in this kind of thing, but it's very public. So all our results, all our quality measures will be posted. There's a financial opportunity if we save money compared to what Medicare thought we were going to cost for those patients. And we get every dollar we save, we get 50 cents, right? We have to meet a certain threshold. There's other qualifications, but essentially this is that fiscal model. There's the ROI model. There's the possibility of a business model which allows the business-minded folks among us to say, I'm going to invest in this world. It used to be lovely to talk about, but now there's actually a potential to return on my investment, and I'm willing to go here. That's really what that vehicle allowed a lot of people to come to this table and move things forward. There's also a financial penalty, depending on our quality and other things. Interestingly, we're all in it together, so there's no more like everyone's reporting on their own. Everyone in that whole group of the ACO, all the providers get the same score. So it really kind of gives you this level playing field where you feel like you're part of something for better or for worse. And again, the statewide collaboration, which we talked about. No surprise what we're focused on clinically, hospital and ED visits, right? Increasing our primary care base, understanding how to manage primary care in chronic disease in particular. We're the program that we built through Bridges, which was the CareLink program, the care coordination program, has been sort of moved up, and we're using that at the statewide level in different ways and to different degrees in each healthcare system based on their own resources. But the idea is that it's a strong care coordination platform. There's data that's starting to support the effort so we can understand where we're going and where we're doing well or poorly. And we're going to try and really lead a conversation. So the first year was a lot of infrastructure and culture. I just had a call this morning with all the medical leaders from Bay Health and Nanticoke and Beebe and Atlantic General and Christiana. And basically they all committed. We're doing COPD. We're doing it across all the institutions. We're doing assessments of how we're doing, what barriers exist to the systematic practice of care. And we're going to use that to then manage locally to achieve something sort of much more globally. And then we're going to move on to CHF and diabetes. Not that these conversations haven't happened before, but they've never had a vehicle like this as sort of a shepherding or overarching framework to make sense of these efforts and to force some of the collaborations. We're seeing conversations between hospitalists and primary care docs that just never happened before. It just never happened. But now we have a vehicle where we're all accountable for this, and it pushes those conversations in a way that they hadn't before. Quality measures, a set number of quality measures we have to report. This is an onerous process that starts on Monday for us, and we have to sample upwards of 2,800 patients on these 18 different quality measures out of 20 different EMRs. Anybody want to help?
So are these only Medicare patients?
Fee-for-service Medicare only. Good point. Yep. So this ACO was fee-for-service Medicare. The Quality Partners Initiative was commercial Christiana Care employees and dependents. So I always talk about it as you're in a car, but we want to be driving in both lanes, right? So there's a commercial lane and there's a Medicare lane. And that has important implications for what we're doing next. But yeah, so these are quality measures. They're interesting. We can go through them in more detail if interested. But, okay. So last slide, and then, I'm sorry, we only have 5 minutes. I'm going to blame that on the food. 5 minutes for discussion. But interestingly, the state has really rich resources. This is through federal funding, but for practice transformation support. And so this in the lower left corner, this is from the Delaware Center for Health Innovation, which was established after getting and I won't get the terms right, so Bill or Tim, if you know what they are, Brian, what is it? Oh, that's right, me and us. Yeah, the SIM, the State Innovation Model. Thank you. Yeah, so it's a State Innovation Model. It was a CMMI award. Delaware was, I think, in the second cohort, but got $5 million. Yeah, maybe even 10, maybe a little more, somewhere between $5 and $10 million to look at what they're doing. So Brian's really active in sort of the healthy neighborhoods portion. I know others are involved. There's a clinical. They've done all this stuff. Anyway, one of the things that they did was put a lot of money into practice transformation vendors. On the delivery system side, there's a lot of other things that are sort of state system and other sort of improvements across the state that relate to healthcare. But this portion put a lot of money in, so the primary care practices across the state can actually take advantage of paid consultants, so they don't have to pay for them. And there were different vendors and the whole process, and primary care doctors can sign up to have these consultants come into their practice and walk them through a set of milestones to help them transform towards a patient-centered medical home. So really interesting resource, very unique to Delaware, thankfully. And then the one in the upper right is actually also a CMS grant that went to Bay Health. It's called Health Visions Delmarva, which actually they have responsibility for the same kind of effort, but in New Jersey, Maryland, and Delaware. So they have about 2,200 practices signed up now. Because of what we had in Delaware for primary care, in Delaware we've chosen to focus their efforts on specialty practices. So a lot of practices have taken advantage of that. Similar idea, paid consultant, all the costs are covered. You just need to show up and do the work in your practice. So really like a ground up effort to have each practice be highly effective and functional in their most granular unit. And I promise you, well, not only 3 minutes of conversation, but what's a VI scholar to do in this, right? I like to think there's like unending opportunities, right? For those of you who are interested in seeing the world a better place. I mean, I go back to my little naive view of the world when I was the chief resident, and somebody said, what do you want to do with your life? And I said, I want to use data to make Delaware a better place. Like, I don't know what that means or how to do it, but that's what I wanted to do, right? And here we are all these years later, and I think we have much more tangible opportunity than I ever could have imagined having to do that. And we're going to need the skills that the VI has and the VI scholars in the organization have to do that well. And we're going to need people to jump in and capitalize on it. So there's pressure everywhere on quality, clinical standardization, efficiency, and cost elimination. I know you already have a lot of efforts sort of engaged around pieces of that. For me, appreciating the broad perspective is huge, right? I'm a concept guy, big picture guy. So if I don't know where my work fits in, I kind of just, I don't know, I can do anything. No. Go back and look at your portfolio, right? And see where it fits and be able to know that you're, wherever you are, if you can make that argument and figure out how it fits in, you're solving a smaller part of a larger problem. Keeping that narrative alive, I think it's meaningful to you, but it's also meaningful to the organization. And then certainly looking for ways to leverage our developing clinical partnerships, data sources, et cetera, that come out. I think there's great opportunity there for a lot of people to get involved and to see that I have a real passion for making this work. And there's scholarly part of this to make it work the best that it can. So thank you for your time, and I hope you enjoyed lunch. And I'm happy to, I'm around, I can stay.
So as expected, Dan, it was a great summary, and congratulations on all you're doing. It's really fantastic work. And it is a microcosm of the United States, right at the center of it. So let me go back to the beginning on the Affordable Care Act. I was listening to NPR driving to work the other day, and probably several of you have heard it. Zeke Emanuel was being interviewed, and he said he's optimistic that things are going to turn out okay. So, from his mouth to God's ear, and he said there are only so many ways of organizing things, and no matter who you are, you're going to run into those limits of how you organize things. So, if we are to organize health insurance around chaos that we had before, mandates that we've got, or Medicare for all, we begin to run out of options. There are probably some others, but basically, I think that those are they fall into those logical kinds of buckets. So if the tremendous amount of the opposition was around the mandate, and they want to do away with the mandate, but there is no political consensus behind Medicare for all, where we're going to be. Do you have any idea?
Oh, man. I was going to say I'm optimistic, too. I really, and it was kind of funny because like everybody else, when I saw the headlines the day after the election, and, it's just like, what just happened, right? I actually was like, wow. He's such a non-traditional candidate, for one. I don't know. We didn't have any idea at that time, and nor do we now, really, how he's going to govern. We have some ideas. But if anyone could just say, I'm going to go a different direction than I said I was going to go before, right? He's the guy. He's proven that. So I think that from that perspective, the political process, the words out there will change, because I think he's going to become a pragmatist there. And I think the congressional understanding is already there, that we can't do what we've talked about doing unless we do it together. I agree. I don't know where they're going to coalesce. It's going to have to be incremental. Keep in mind, Obamacare, as big as it was actually incremental, right? Which is crazy to think about. So I think you're right, though. You have to decide which incremental things are you willing to accept and which ones are you going to let go of? And that's going to be a hard thing. I don't see loss aversion, right? You're the behavioral economist among us, right? Loss aversion is always the strongest and most painful thing, right? You have 20 million people who have new health insurance. That is going to be a painful uprising if that goes away. No one in the political process is going to let that happen because they won't survive the next election, right? So there's a practical, political practicality that's going to come over this debate, and as long as we can get sort of the bombastic meter back towards center a little bit, I think we're going to be in a better place where the political process will go. What you have right now is Democrats entrenched because they're afraid, right? And Republicans sort of riding the, here we're going to go. That's going to have to settle out, and it's going to go back to a long slog. Where I'm optimistic is you have 6 years worth of experience now, whereas before it was all theoretical conversation. So you actually have, what did we like, what didn't we like, why were our cost projections so off? I think there's a whole level of maturity as a country and as an industry that hopefully will help. As we hang our hat on the next thing we're going to chase, I hope it'll inform that conversation. So no specifics, of course, but
yeah. Enjoyed that greatly. I'll make a couple of comments specifically about trauma. And the ACA helped trauma a lot. I can't speak specifically to us, but there's been 3 or 4 very good papers, studies that have shown improvements in outcomes with the ACA.
Yeah.
The institution of the ACA, because we've known for a long time, it's not just due to trauma, underinsured patients don't do as well as patients who have insurance. There was a national experiment, one of the DC trauma centers, they presented a paper at our region meeting just recently. They get patients from Virginia and Maryland, and I believe Virginia did not go with the Medicaid subsidiary, and Maryland did. And within their own institution, the patients from Maryland did better than the patients from Virginia. And so we're, at this particular meeting, we're very concerned about this. I'm not familiar with, you hear that, okay, with the ACA we increased insurance to this many more people. You don't hear as much about we improve the outcomes in these people.
Yeah.
And we've had some very good studies in trauma that says it has.
Yeah. And
so we're very concerned.
Yep, and they're beyond trauma too. There's data.
I'm sure there's other
access to health care and a lot of those things we use we know that the relationship is there and we believe in it. But you're right. I heard somebody say, from the trauma standpoint, they used to always they always have make people after abdominal trauma live the rest of their lives with colostomy as opposed to doing a diversion and giving them the surgical fix in the way that you would prefer to. And trauma surgeons living at that place where you're making decisions that I don't want to do this for the patient, but my hands are tied and I have to do this because that's all that gets paid for, et cetera. No provider wants to be in that space, right? And that's why the AMA and the ACP and other provider-based organizations have come out strongly just saying, listen, right now, we're not worried about everything else. Just don't repeal right now. We'll work out the details where we go forward, but don't take this coverage away because it starts to rationalize the market and rationalize our experience of healthcare in a way that we all, I think, intrinsically appreciate and know is right. So I don't see how that doesn't trump the day. Marcy.
So you mentioned how drug costs are driving a lot of the increase in costs. So where does Big Pharma fall into this? And I think, one of the faults of the Medicare Part D expansion is that the federal government was not allowed to negotiate drug prices. So, like in my field, a course of curative treatment for hepatitis C costs $100,000 here. It costs $1,000 in Egypt. Yeah. And obviously, there are drug development costs and everything, but that's breaking people's budget, and it's really denying what is life-saving therapy, and it's solely based on cost that people are not having access to this. So, I mean, is there talk of pharmaceutical reform as part of all this as well?
It's huge. The Republican Part D expansion, it's always amazing how we look back at politics, but Medicare Part D was passed under George W. Bush, right, with Republican support. If you look back, I don't even understand. Sometimes people, I think, turn themselves so far around in the conversation, I don't remember what they support and what they don't support, right? Because it just made no sense from a Republican to be pushing that forward in a lot of ways. But because it was a Republican bill, it kept some of these things in it, like market competition, et cetera, no government contracting and pricing. That's being looked at. It's got a bullseye on it. There's a huge, that's been a Republican idea that they've held to, that we don't want to do we don't want to negotiate drug prices. It has to change. I mean, it's irrational. I think some of the things with the different drugs that you've seen over the last couple of years that have come out and been just such egregious, offensive kind of pricing strategies, I think has actually given people now when people say big pharma, they say it with even more sort of frustration and anger than they would have even 5 years ago, because you start to see some of the things. So it has to be on the block. Again, if you look at only Nixon could go to China, right? I think Trump, if he chooses to govern this way, can lead in a direction that no other Republican could have, just because he's so sort of free to be himself. So some of those things that were previously sort of sacred cows under Republican ideology may be up for grabs, depending on how the things shake out.
He said that in particular about the drug prices.
Yep. No, he said some things that sound very rational.